Hey everyone, today's video is on hyperparathyroidism and its surgical management. Of course, there's a lot of endocrine physiology related to the parathyroid gland that we could cover. We're going to keep this video simple and surgically relevant. So first, what is hyperparathyroidism? Of course, the primary action of the parathyroid gland in the body is to secrete parathyroid hormone, which of course regulates calcium levels. And so in hyperparathyroidism, at least one of these glands is hyperactive. So you get an increased level of PTH in the bloodstream, which is going to lead to increased levels of calcium and lead to symptoms related to excess calcium in the body or a lack of calcium in the bones, is another way to look at it. This is usually caused, probably about 80 to 85% of the time, by a parathyroid adenoma. So that one hyperactive gland actually has a benign growth of parathyroid tissue that's secreting that excess hormone. But the other 20 to 15 to 20% of the time, it's something else. Most common after adenoma is hyperplasia, where all four glands are hyperplastic and secreting a bit more than normal, but there's no single culprit. There's also even less common situations where you could have multiple adenomas, and very rarely there's parathyroid cancer. This is less than 1% of the time, and we're not going to really focus on that in this talk. When we talk about hyperparathyroidism, there's three types: primary, secondary, and tertiary. And to briefly cover the difference there, because not all of these get operated upon, primary hyperparathyroidism is kind of exactly what we just discussed, where there's an issue with the parathyroid glands, and that leads to an increase of PTH. And that increased PTH drives an increase in bloodstream levels of calcium. Again, that's primary hyperparathyroidism. This is by far the most common. Secondary is a bit reversed. So in secondary, first you start off with a patient in renal failure. So their kidneys give out. And when your kidneys don't work well, you get low calcium. This is related to the kidney's production of activated vitamin D and some other issues with electrolyte imbalances. But all you need to know is in type 2, you're in renal failure, and this leads to low calcium. So the body has a normal physiologic response to increase the parathyroid hormone, trying to regulate the blood calcium levels appropriately. So again, type 1, increased PTH, like we talked about, leads to increased calcium. Type 2, renal failure leads to decreased calcium. That decreased calcium leads to an increased PTH. And so type 2, we would never operate on for taking out the thyroid glands, right? Or the parathyroid glands, because this is a normal physiologic response. Um, I guess you could say we could do a kidney transplant, but you certainly would not do a parathyroid surgery. Now, type 3 is an interesting case where it's post type 2. So a patient has type 2 hyperparathyroidism, or I should say secondary. And in tertiary, that patient gets a kidney transplant. And now their type 2 doesn't turn off, essentially. The parathyroids have been used to trying to compensate for low calcium for so long that they are just hyperactive. So now, again, in type 3, we have that issue where these overactive glands don't shut off with the new good kidney function, so you have increased PTH, and then we do get increased calcium and those symptoms. So when we're thinking about surgical management, we would operate on primary and sometimes tertiary hyperparathyroidism, but you would not operate on secondary. So that's why it's important to have that distinction in mind. But again, back to the diagnosis. What's really interesting about this is it's one of the few surgical diseases that is a purely biochemical diagnosis. All you need is laboratory values. If your PTH is elevated and your calcium is elevated, you by definition have hyperparathyroidism, and there's really no other data that you need to make the diagnosis. Now, sometimes you might want to rule out something else. If you have a high PTH and a high calcium, it's most likely primary hyperparathyroidism. There's a few other things it could be. Primarily, the other thing to rule out is familial hypocalciuric hypercalcemia, or FHH. This is a hereditary condition with a slightly altered calcium sensing receptor in the parathyroid glands. Long story short is that it leads to less dumping of calcium in the urine and a chronically elevated calcium level in the bloodstream. Now, you don't always have to check for this though, because frequently we diagnose hyperparathyroidism incidentally on just general blood work. And so frequently these patients will have blood work going back, many years previously. And if the elevated calcium is new, that is to say, if their prior blood work shows normal levels of calcium and now it's new, you know that's not going to be FHH because this is a hereditary condition that would lead to increased calcium throughout the lifespan. However, if you don't have those previous lab values to compare to and you're concerned, you rule out FHH with a 24-hour urine calcium level. If that's normal, and they don't have FHH. So, if all this is a biochemical diagnosis, does everybody with an elevated PTH and calcium get surgery? You might imagine if you just found this on labs, you're going to have not insignificant amount of patients that are actually asymptomatic at presentation. And frequently, we don't offer surgery to patients who are asymptomatic from various conditions. So, how does this work? So first, anyone who's symptomatic does get surgery. And this can get a little bit difficult because elevated calcium can cause some relatively nonspecific symptoms. So, the classic description that's found in textbooks and board reviews and things like that for symptoms of hyperparathyroidism are the stones, bones, groans, and psychiatric overtones. And so that stands for the stones are for kidney stones, the bones are for fragility fractures or osteitis fibrosis cystica, where this hyperparathyroidism is just eaten away at the bones over time. Groans stands for abdominal pain. And then moans, or sorry, moans or psychiatric overtones is these neuropsychiatric symptoms that are kind of broad and nonspecific, like fatigue, weakness, depression, and memory changes. So the point is, it's pretty easy to find some sort of symptom that your patient might be experiencing that you could call symptomatic hyperparathyroidism. Also, even patients that are asymptomatic, if they have certain characteristics, you would offer them an operation as well to cure their hyperparathyroidism with surgery, which is the only definitive cure. So, if their hypercalcemia is bad enough, so if they're greater than 1 milligram per deciliter over the normal limit, you would offer them an operation. Or if they're a young patient where you'd expect this to progress over their lifespan, so if they're a patient less than 50 years old, remember these are all ors. Any of these classifications would lead you to offer them an operation. They don't have to have more than one. If they have definitive renal symptoms, specifically creatinine clearance less than 60, kidney stones or nephrocalcinosis seen on imaging, or skeletal manifestations. And this is primarily revealed through DEXA scans if they have a T score less than negative 2.5, or if they've had um, any vertebral fractures in the past. You would consider that a skeletal manifestation of hyperparathyroidism, and you would offer them an operation as well. So the big take home here is that most people get surgery. They either have to be very completely asymptomatic or very, very poor surgical candidates. I mean, this is a really superficial, relatively minimally invasive surgery in the neck that most people can tolerate quite well. So most people with hyperparathyroidism do end up getting surgery to manage their condition. All right. Now, one thing that is absent from this talk so far that we usually do talk about quite a bit in preoperative planning is imaging. And what's interesting is the classic treatment for hyperparathyroidism is a four-gland exploration where you just go in the neck, look at all four glands, and take out the most abnormal one. And for that, you do not need any preoperative imaging. Nowadays, people are trying to make surgery more minimally invasive, and we usually actually do what's called a MIP or a minimally invasive parathyroidectomy, in which case you like to only dissect on one side of the neck, the side that has the adenoma or the problematic gland. And so there are usually some sort of imaging studies done. Probably the most common is just a neck ultrasound, often even done in the clinic. This will identify an adenoma quite easily. However, if the ultrasound's not successful, you might use more advanced forms of imaging. You can use a sestamibi scan. Sestamibi localizes to the parathyroid glands pretty well, and you can look for abnormalities there. And finally, there's also 4D CT scans. These are quite excellent, especially for the parathyroid glands in abnormal locations like down in the chest, etc., where an ultrasound, for example, could not see past the ribs. But again, I want you to know that you don't technically need any imaging. I'd say ultrasound is probably the most common one I see to help with localization. But this is more in situations where you're going back, redo surgery, looking for hidden glands where you might look for sestamibi or 4D CT scans for localization. All right, so back to the surgical focus. Let's talk a little bit about some parathyroid anatomy. So when we're planing our incision, you want to palpate the cricoid cartilage, which is usually kind of up at the top of the trachea. And you want to go about 2 finger breadths below that, which is where you anticipate the thyroid isthmus to be, which is, of course, just that center part of the thyroid. As you might have guessed from the name, the parathyroid glands are located around the thyroid. They're actually posterior to the thyroid, but I'm just going to draw them kind of in front of it. They're these tiny rice-sized glands that look like little fat globules. They're actually quite hard to find, so you really need to know the surrounding anatomy to help guide you to them. So you have 2 superior glands here. Again, these are behind the thyroid, and then 2 inferior glands down here. The blood supply comes from the inferior thyroid artery, and it comes in medially. That's going to come into importance later, we'll talk about. And then finally, there's a very important structure that runs very close to the thyroid glands called the recurrent laryngeal nerve. This comes off the vagus nerve, where the vagus nerve hooks around the subclavian artery on the right or the arch of the aorta on the left, and it comes back up towards the trachea and actually passes right in between these 2 glands before finishing its course in the tracheo-esophageal groove and innervating many muscles related to breathing and phonation. And so if we look at our inferior glands, those are anteromedial to the recurrent laryngeal nerve here, while the the superior glands are posterolateral. That's really important actually in the OR to help you both find the glands and preserve this nerve from any damage. Of course, there's a lot of other important structures in the neck. You've got your trachea back here. There's the esophagus kind of back here and to the left. Out here laterally, you have your common carotid artery and your internal jugular vein and your vagus nerve. But when it comes to what structures we're really hunting for in this operation, it's going to be primarily the parathyroids as well as the recurrent laryngeal nerve. And the reason we're hunting for that nerve is that there's really 2 dreaded complications of surgery for hyperparathyroidism. The first relates to that nerve. So if you injure the recurrent laryngeal nerve, the primary concern we have is that it innervates the vocal cords and it pulls the vocal cords open. And so if you injure the laryngeal nerve on one side, that's not ideal, but it's okay. Frequently, it's a traction injury that recovers, and the patient just has a little bit of hoarseness for a few months while that recovers. However, if you do this bilaterally, if you hit the recurrent laryngeal nerve bilaterally, the vocal cords collapse medially and shut off the airway, and those patients cannot breathe post-op. So you'd extubate them, they'd be unable to breathe. They would then need a tracheostomy to breathe for the foreseeable future, if not the rest of their life. So that is, of course, a horrible injury that buys someone a trach and compromises their airway. The second terrible complication is hypoparathyroidism. Remember, we're treating hyperparathyroidism, but having no parathyroid hormone is arguably just as bad or worse as having too much. Remember, these glands, like we talked about in the last slide, are very small, hard to find. You can accidentally damage them with their blood supply in the dissection looking for the problematic one. And if you knock out all of these glands, these patients have terrible hypocalcemia, really low blood calcium. And calcium is, of course, critical for normal neurologic function. Worst case scenario, these patients can go into profound diffuse tetany and even die from low calcium. So if they are left with severe hypoparathyroidism post-op, they're on a ton of calcium supplementation for life. They have a lot of symptoms from that. They're miserable. And so remember that when a lot of them are either asymptomatic or minimally symptomatic pre-op, you really do not want to cause them hypoparathyroidism post-op and leave them worse off than you found them. All right, so let's briefly talk about our surgical options. Remember, most of these are caused by a single gland being problematic with a single adenoma. So most patients just get a parathyroidectomy or a removal of a single parathyroid gland. This can either be done with a 4-gland exploration and then taking out the one problematic one, or if you do pre-op imaging, you can usually zone in on the one that you think is wrong and just take that one out. So that's called a parathyroidectomy, or if you dissect just the one side, a minimally invasive parathyroidectomy. Your other option, remember that a not insignificant amount of these are caused by hyperplasia of all four glands. And when that's the case, you do what's called a subtotal parathyroidectomy. And that just means you take out almost all of the parathyroid tissue in the body. So you take out multiple glands. This was classically described as taking out 3.5 out of the four glands that you have and just leaving that half a gland attached to its medial blood supply. Remember, these blood supply come medially, so you'd have to take the lateral half of that parathyroid gland. But what I've seen in practice, and I suspect is more common nowadays, because remember the risk of hypoparathyroidism. If you bugger up that last half a gland, that patient has no parathyroid function, is going to have lifelong hypoparathyroidism. So most people will actually just take out 3 out of 4 glands and then see how the patient does post-operatively. Usually, that's going to be enough to decrease their parathyroid hormone enough to minimize their symptoms. And so, what you do in this case is you explore all 4 glands, you identify what you think is the most normal gland, and you would take out the other 3 and leave that fourth gland. Sorry. The other option with this, if you do think you've devascularized that last gland, is you can reimplant parathyroid tissue back into the body, either in the SCM in the neck or even in places like the forearm, in the muscle there. If you take out a parathyroid gland and you're worried that they're going to be hypoparathyroidism, you can actually reimplant that tissue, which is kind of wild, but does actually tend to work after a few weeks when it gets its blood supply developed. All right, a few more operative considerations. One, we talked about how terrible that nerve injury is. Can we prevent that nerve injury? And the answer is there's not really any operative strategy to prevent nerve injury besides just careful dissection and identifying the nerves. But you can use nerve monitoring in the operating room. This is a special type of endotracheal tube that has sensors right by the vocal cords, and it allows you to stimulate what you think is the nerve in the body, and then it will give you a corresponding stimulation of the vocal cords, and that's picked up by the machine. It allows you to both identify what you think is the nerve and give you some peace of mind that other tissue that you're dissecting is not the nerve. And while this won't prevent nerve injury, this can help you identify it. And so, let's say you're dissecting on the left side and you identify that you lose your nerve signal. Now you know you should not go look on the right side to preserve the nerve there. And you can maybe finish the case, close the patient up, come back another day when they've clearly got bilateral nerve function, and then do the other side. And then you won't have a risk of taking out both nerves at once, which is the really catastrophic injury. So again, nerve monitoring is almost always done in these operations. The next question is, am I done? Or, how do I know I took out the right gland if there's one problematic gland? And what's really interesting is parathyroid hormone actually has a very short half-life, something like 2 to 3 minutes. So we measure PTH levels baseline at the start of the operation, and then again after we take out the gland at 5, 10, and 15-minute intervals. And if you've taken out the right gland, you can see a profound drop in the PTH in just those 5, 10, and 15 minutes. And I think different institutions have different cutoffs. At ours, we like it to drop 50% at least from its baseline, and we want that 50% drop to leave us with a parathyroid hormone level in the normal range. And if it does that, usually at around the 10-minute mark, then you know you got the right gland and you can finish the operation. Finally, a lot of these patients remember that the remaining normal glands are going to be suppressed by the high calcium created by the adenoma. So a lot of them will have some transient post-op hypocalcemia while those glands recover. This is fine. Just know that your patients are usually going to be on some calcium supplementation for a few weeks post-op, and have some as needed calcium that they can take if they get symptoms of hypocalcemia, primarily numbness and tingling in the extremities or around the mouth in the perioral space. All right, so a bit of a whirlwind there. We talked a lot about the physiology, surgery, and anatomy related to hyperparathyroidism. So a quick review. One, remember that hyperparathyroidism is a bit unique in surgical diseases in that it's a biochemical diagnosis only. All you need is the lab values with an elevated PTH and elevated calcium to make your diagnosis. most patients do get surgery. So if you see this biochemical diagnosis, you need to look for just those few reasons why patients would not get surgery. But for most patients, even asymptomatic ones, you're going to be offering them surgery. Remember, even if they're asymptomatic, if their calcium levels are very high, greater than 1 above normal, or if they have any evidence of renal impairment, skeletal symptoms, or their age is less than 50, you're still going to offer them surgery. Remember, this is a very safe surgery, especially in expert hands and high volume centers. But since many of these patients are asymptomatic when they come in, you have to really balance the risk benefit of this operation with the potential complications of parathyroid surgery, primarily hypoparathyroidism or bilateral recurrent laryngeal nerve injury. And I think that's it. So this video is for educational purposes only. Do not use to diagnose or treat any diseases, and we will see you next time.